So, hello, back again. My name is Tramér. I'm from Geneva, Switzerland. I have the great pleasure to moderate this second morning session. We have 4 talks. We will talk about bias in reporting and publication of research. And the first talk will be given by Gaelen Adam, Augmenting Systematic Reviews with Information from ClinicalTrials.gov to increase transparency and reduce bias.
Hi. Let me bend this down a little more. My name is Gaelen Adam, and I'm here representing 4 teams of researchers across multiple institutions who have undertaken a series of projects looking at the impact that searching ClinicalTrials.gov had on a series of ongoing systematic reviews. Before I get started, a bit of background. This research was commissioned by the Agency for Healthcare Research and Quality, a small agency within Health and Human Services in the United States. Its mission is to produce evidence to make healthcare safer and more accessible, equitable, and affordable, and to work with HHS and other partners to make sure that the evidence is understood and used. EPCs, or evidence-based practice centers, are comprised of research scientists and physicians who conduct systematic reviews which provide independent and unbiased synthesis of research. Many derivative products come from EPC reviews, including clinical practice guidelines and policy guidance. In this project, we ask the question, does information from ClinicalTrials.gov impact the conclusions of a systematic review? What additional resources are needed to incorporate that information? What patterns did we see in terms of potential biases and transparency? And when is it worthwhile to do these searches? Some terminology before we get started. In this presentation, a study is the actual research conducted. A record is the ClinicalTrials.gov report of a study, and a publication is the journal article report of a study. For this project, we looked at 5 systematic reviews. All were ongoing projects so that we could measure prospectively the resource use and payoff of ClinicalTrials.gov searches in real time. They were intentionally based in different clinical areas and populations with diseases that range from reproductive and physical health to mental health. They span different types of interventions, including drugs, alternative medicines, behavioral interventions, devices, surgeries, supplements, complex interventions, and so on. Though the methods varied somewhat across the 4 EPCs, in general, they included the following: a search of ClinicalTrials.gov to the last date of the original review search, screening the records using the original review's eligibility criteria, extracting information from the records, and assessing risk of bias and applicability. Finally, we looked at the impact on conclusions and strength of evidence in the report. Some specific variations that are worth mentioning. 2 projects also searched WHO's ICTRP. 1 project reached out to study authors by phone and email, and 4 projects plan to incorporate new results in meta-analyses. In assessing the impact on the systematic review of the records found, we looked at 3 specific things. First, studies that had both a record and a publication. For these studies, we compared the record to the publication in terms of design details, population description, sample size, details about the interventions, outcomes, and results if they were given. The second area was studies that had a record in ClinicalTrials.gov, but with no publication. For these studies, we documented the study status, whether they were completed, discontinued, or ongoing, and relevant dates. We also incorporated the results of these studies into the systematic review if they were applicable and usable. Finally, we looked at studies with a publication but no record. For these, we looked for the reasons why they were not included in the registry. This involves some hypothesizing. So, here's what we found. In general, a large number of published studies are not registered in ClinicalTrials.gov, between 43 and 86%, in part because many are old and predate ClinicalTrials.gov, but also because users may not find ClinicalTrials.gov relevant. In addition, between 10 and 30% of the records did not have an associated publication. However, it is worth noting that these numbers may not be totally accurate, because we found that it was difficult to match records to publications between PubMed and especially where trials were not correctly indexed to crosswalks between PubMed and ClinicalTrials.gov. In fact, one group attempted to automate this matching process to streamline finding relevant records, but were unable to do so, in part because of lack of consistent indexing. For the studies that had both a record and a publication, we found relatively good agreement between the record and the publication, especially when it came to design elements and intervention descriptions. We did find some discrepancies in lists of outcomes, as they were either specified in the record or reported in the publication. For example, in the Omega3 Project, we found that of all the results, 71, a majority, were reported in both ClinicalTrials.gov and the publications. 2, both clinical outcomes, were reported only in clinical trials records, and 25 appeared for the first time in publications. These were primarily intermediate outcomes, lipids and blood pressure, though in 3 papers they were clinical outcomes, including non-fatal stroke, myocardial infarction, and revascularization. That said, we found that the newly reported results followed the same patterns in terms of direction and statistical significance as those that matched. It is worth noting that there are many reasons for these types of discrepancies. One being outcome reporting bias. In addition, it is also worth noting that many records were not prospectively registered. They were created after the study had begun and sometimes after it had finished. This may have led to underestimation of the actual discrepancies between pre-specified and reported outcomes. The group at RTI reached out to 15 authors to ask them why they had or had not registered their studies. The report looked at mental health in children and adolescents, which entail by nature complex and system-level interventions. 10 authors replied, of whom 4 had registered their studies. Of these 4, 3 noted no barriers to registering. 1 noted a mismatch between the nature of the study and the purpose of ClinicalTrials.gov. And 3 questioned the utility of registering this sort of study in ClinicalTrials.gov. Next, we looked at studies that had a record but could not be matched to a publication. The figure on this slide is from the Omega3 Project. The red studies have both a record and a publication in the report. The black studies have a record but no matching publication. Each line is a single study with a dot for its start date and another for its end date. As you can see, the studies included in the report are older than those not included in the report. And in fact, many of those not included in the report were still ongoing at the date of the search, indicated by the solid blue line. However, Johns Hopkins, in their report on diabetic peripheral neuropathy, DPN in this table, found in 7 of the 23 studies with records only, the record had results, suggesting either completion of the study or reporting of interim results. And in fact, 13 of the 23 records were more than 3 years old. An arbitrary cutoff we suggested would indicate results should have been published. They found that for almost all interventions, the new results had no or minimal impact on the findings of the report. But for one outcome, they were able to do an updated meta-analysis. The figure in the slide shows the standardized mean difference in pain scores comparing pregabalin with placebo, stratified by the studies found in the published literature versus those found only in records. The ClinicalTrials.gov records report a less dramatic effect, but the direction is the same. This figure also seems to show more of a temporal pattern rather than one that would necessarily suggest publication bias. This could be a result of time lag bias, or just that early studies are usually done in the populations most likely to benefit from the intervention. Finally, we looked at studies that had a publication but no registry record. Many of these studies were older, were not randomized controlled trials, or were not conducted in the United States. For example, in the Tympanostomy Tubes Project, 172 studies, 54 of which were randomized controlled trials, were not found in the registry search. Looking at the randomized controlled trials, 22 were older than ClinicalTrials.gov's inception date of 2000, and another 13 were not conducted in the United States. So, what does this all mean? What is the value of including registry searches in rigorous systematic review projects? For one thing, you may identify studies not included in the review. For example, we found many records in ClinicalTrials.gov that did not have results or publications, and about 30% of these studies were completed more than 3 years ago. Because of the lack of results, we could not determine whether these studies would have impacted the conclusions of our reports. Another value comes in the ability to compare prospective records with publications to see what the discrepancies between the report and the record are, and whether those are indicative of any sort of bias. But as we found, those differences can be difficult to interpret, in part because of the limited information given in ClinicalTrials.gov and the fact that so many studies are retrospectively registered. Finally, registries can be a good source of information on ongoing research and may be used to help define future research needs. However, these benefits come at a cost in terms of staff time to do the work of manually screening and matching records. Better indexing in the major databases, such as Medline, might improve this and even allow for automation. How can journal editors help? Journals might enforce the requirement to list studies in ClinicalTrials.gov, ideally prospectively. They might also help by creating a format which requires that the registration number go in a certain consistent place in each article to streamline indexing. Thank you.
Thank you very much. Are there any questions? Can you hear me? You searched only in one clinical trial registry. What do we know about non-US studies, for instance, that are registered in other registries?
Well, two of our projects, the Omega3 Project and the Tympanostomy Tubes projects, also did a full search in the ICTRP's, or the WHO's ICTRP registry, which is the International Trials Registry. What we found was that those records, by and large, did not include results. But the other thing we found was, like searching something like Embase in the addition to Medline, sometimes we found ClinicalTrials.gov records that we had missed in our ClinicalTrials.gov search. That registry definitely needs much, much better indexing to make it more usable, and they need to move towards including results in their records.
But should we actually encourage authors from non-English speaking countries, for instance, and I'm representing a journal where 2/3 of all submissions are coming from non-English speaking countries, should we encourage them to register their study protocols in one of these big international or US databases, or shall they register in their national databases, China or India or whatever?
Well, from my perspective, I think so long as it's consistently indexed and we can access those records, it doesn't really matter.
Should it be in English?
Is the publication in English? If the publication is in English, maybe they should be in English.
Yeah, Mark Mark Helfand, Portland, Oregon. Do I need to turn it on?
We hear you.
Oh, good. Okay. Well, there it is. Okay. Yeah. My question is about the measures that you used, particularly the one where you had a slide of a meta-analysis result and says, oh, here's what this would have added. Let me give you, my concern is that that may be a pretty limited way of looking at the impact of ClinicalTrials.gov results. And most of this is about the registry, what studies exist, what did they measure, how many outcomes, and so on. But this is more about those that had results in ClinicalTrials.gov. And other people would come from the exact opposite, or very opposite direction. They'd say, well, what outcomes are reported in ClinicalTrials.gov, and are they in the journal publication, or are they reported differently? You talked about discrepancies, and you talked about adding to a meta-analysis. So let me just ask this. There's a drug that's now out for a couple years now that's used for a relatively rare cancer. The journal article, which was published in New England Journal of Medicine, along with voluminous supplements and the protocol and everything, didn't actually mention the quality of life results. In order to find them, the only place you could find the quality of life results was in ClinicalTrials.gov. Therefore, there wasn't any pooling or any meta-analysis of that outcome in a systematic review. And the impact would be, gee, if you're looking at this, you should know that the quality of life impact was practically none. You wouldn't know it from the journal article, and of course you can't tell it from protocols or from registry entries. How would an impact like that show up in your study? Could a systematic review that hadn't planned to do a meta-analysis of quality of life in the first place be changed by saying, you know what, we found out that they had no impact on quality of life? Or did you only look at impacts on, meta-analyses?
No, that's an excellent point, and that's where being limited to a 10-minute talk makes things a little tough. That is, in fact, that quality of life, new results reported in ClinicalTrials.gov records are a real source of information for systematic reviews. In several of the systematic reviews we've done subsequently, we've found data in ClinicalTrials.gov records, particularly actually as it pertains to adverse events, which ClinicalTrials.gov is very strict about how they're reported, much, much more strict and much more complete than the journal articles tend to be. So that's an excellent point. If you can find new information and new results in ClinicalTrials.gov, that will, of course, have an impact on the resulting systematic review.
Please.
Hi, Christine Rasmussen from the Nordic Cochrane Center. Thank you for an interesting talk. I was wondering, in your last sort of comment, you were mentioning that editors could help with this, and I was wondering whether you think the responsible people should be the funders of the study, or the investigators or authors in terms of registering a trial, or even trials that have been conducted already. Could you say, well, editors could say, we will only allow to publish your study if you also register previous studies that we know you've conducted? Would that be an option?
I think that would be fantastic. I mean, as a systematic reviewer, the more information there is, the happier we are. I think that we do a lot of sort of, not really denigrating or criminalizing, but putting a lot of this stuff on the researchers and saying, you're creating biased studies, you're not registering things prospectively, you're doing selective outcome reporting bias. And I think that, we need to and maybe I'm being naive, but we need to go on the assumption that they are scientists and they're trying to do good things. So if we can give them a format and say, this needs to be registered, it needs to be registered prospectively. Funders are much more involved in saying that you have to register your trial if you're going by a certain point, if you're gonna, get our money. So I think that that's really important. I think that to the extent that we can make this stuff easy for them, as in saying, here's a box, put your ClinicalTrials.gov or any other registration number in this box. You know, that will allow crosswalks, it'll allow identifying these things better, it will reduce staff time for systematic reviewers who are trying to match these records. I hope that answers the question.
Okay, any last question? Nothing? Yeah, just very quickly, 30 seconds.
So I noticed that on ClinicalTrials.gov, I did a search, about 60% of clinical results were not provided with statistical analysis. So they're just raw results. So what do you think about the utility of ClinicalTrials.gov for an average patient or clinicians who may not have had statistical training? So even if the results are shared, and the systematic reviewer can use them probably, but they're not interpretable for people without training. So what do you think? Is it important, and should we add?
I think that that's another very good point. I unfortunately can't get in the heads of people who are designing ClinicalTrials.gov, but I think that it's got to be a real challenge to be trying to create one database for all of us, patients, clinicians, systematic reviewers, researchers. And I think that, you know, one thing we found was that sometimes the results were only given after some sort of statistical analysis, and we couldn't go back to the raw data, and therefore we couldn't incorporate them in our meta-analyses because we couldn't get to the metric we needed. So I think that what is reported in ClinicalTrials.gov, you know, it needs to, you know, we want the raw numbers, and we need to know what the analyzed results are, what they mean, and what they were corrected for in a perfect world. Thank you all.
Thank you very much.